Welcome back to the deep dive. Today we've got a whole stack of sources, everything from core anatomy mnemonics to some really specific guidelines on digital blocks.
Right.
And we're going to boil all of that down into the absolute essential maneuvers and I guess the diagnostic triggers you need to use on your next shift. If you're an emergency practitioner or a doctor revising this topic, this one is really for you. We all know hand injuries are just a massive part of the workload.
Oh, absolutely. It's something like, what, 20% of all ED attendances in the UK? It's huge.
Exactly. But here's the thing that always gets me. That small cut, little crush injury, it can be hiding something truly devastating.
A life-changing injury. A tendon, a nerve.
Yeah, something that can completely change a person's ability to work or, live their life. So our mission today is to get past that basic triage and stop missing those deep injuries.
That's the core of it, really. We're aiming to give you the highest yield clinical pearls, the specific steps to assess these complex cases properly. From the moment they walk in, right through to medico-legally sound documentation.
Okay, let's dive right in then. I want to start with the big four. The four clinical tramps that really separate a standard assessment from, an expert one. First up, the one that causes immediate anxiety for everyone, the fight bite.
Right. The rule here is simple, but it gets missed a lot. Any cut, any laceration over the metacarpal head, over the knuckle, you have to treat it as a human bite until proven otherwise. Full stop.
And the mechanism is key here, isn't it? It's not just a simple slice.
Not at all. You have to imagine it. The patient's hand was a clenched fist when they hit the tooth, so the skin was pulled tight, proximally.
Okay.
Then, in the ED, they open their hand. The wound on the skin now doesn't line up with the hole they punched in their joint capsule.
So you get this open pathway straight into the joint, just teeming with nasty oral bacteria.
Exactly. That's why the risk of septic arthritis is so high. It demands an aggressive washout and critically mandatory antibiotics. It's a non-negotiable.
Okay, trap number 2 deals with alignment, and this is one you can only spot if the patient moves. Rotational deformity.
This is an absolute must not miss. If you miss this, you're committing that patient to permanent functional problems.
So how do you spot it?
You have to watch them actively make a fist. The key sign is the scissoring of the fingers on flexion.
They cross over each other.
They cross over, even slightly. And that's the absolute hallmark of a malrotated metacarpal or a phalangeal fracture. You can accept some angulation in certain fractures, but rotation, never. It's unacceptable. That needs a surgeon.
And that links nicely to our third trap, which is also about the geometry of the injury, the position of injury. Why can't we just, look inside the wound as it is?
Because of how tendons work. Think about it. If the finger was bent when it was cut, the tendon was under tension, right? The moment the patient relaxes their hand, that cut tendon end retracts. It can pull back centimeters away from the skin wound.
So if you just look in with the hand lying flat, you'll see nothing. The injury is gone.
Precisely. The pearl is, if you suspect a tendon injury, that wound has to be explored through its full range of motion, and really that means under a good digital block so the patient can tolerate it.
Okay, and the fourth trap, the immediate red flag for a surgical emergency. Kanavel's signs.
Yes. This is your signpost for flexor tenosynovitis. Basically, an infection sealed inside the tendon sheath.
And that's a closed space, so pressure builds up.
Terribly. The pressure and the pus just destroy the tendon's blood supply. It's a true surgical emergency. We'll detail the signs later, but for now, just know that name. It's aggressive, it's urgent, and it means admission and a washout.
Perfect. This is where a quick anatomy refresher really pays off. Can you give us the rapid-fire version, but link the structures back to those clinical risks we just talked about?
Absolutely. So, let's start with the carpals. Everyone knows the mnemonic. Some lovers try positions that they can't handle.
A classic.
It is. But the clinical point is really about the scaphoid. It has this weird retrograde blood supply.
So it dies off easily if it's fractured.
Exactly. It's incredibly prone to a vascular necrosis. And that's why, with the scaphoid, your clinical exam trumps a negative initial X-ray every single time.
Okay. And the metacarpals.
Think of them as having two functions. The second and third are your rigid stability pillars. They're for strength. But the fourth and fifth are mobile.
To let you grip things.
Right. That mobility lets the hand cup and adapt. And that's also why we can tolerate more angulation in a boxer's fracture of the fifth metacarpal. It has that built-in compensation.
And the engine room, the flexors, FDP and FDS, how do we keep them straight?
It's all about where they insert. The FDP profundus is deep. It runs all the way out to the distal phalanx. It's the one that bends the tip of your finger. The FDS, superficialis, is clever. It actually splits in two, creating a little window called the chiasma of Camper.
And the FDP passes through that window.
Correct. The FDS then attaches to the middle phalanx, so it bends the middle joint, the PIPJ. If you remember that split, you'll understand how to test them separately.
And finally, the structures that hold it all together. The pulleys. We always hear about A2 and A4. Why are those two so important?
They are the non-negotiables. The A2 and A4 annular pulleys are these super strong, fibrous bands that hold the flexor tendons down against the bone.
Like a guide on a fishing rod.
Perfect analogy. Without them, when you try to make a fist, the tendon would lift away from the bone. It's a phenomenon called bowstringing. All the force is lost. You lose your grip strength. Their integrity is absolutely critical.
That anatomy makes the assessment so much clearer. So let's move to that, the history. What are we asking beyond just what happened? Two things, straight away. Hand dominance and occupation hobbies. You must document these.
Why so critical? Well, a tip of the index finger injury in a dominant ham concert pianist is a catastrophe. The same injury in someone else might be, less functionally devastating. It completely changes the context, the rehab, everything.
And we should be using the mechanism of injury to predict patterns.
Right, absolutely. You hear crush, you think compartment syndrome, you hear high pressure injection.
Surgical emergency.
Massive surgical emergency, even if it looks like a pinprick. The chemical necrosis inside is extensive. You hear punch, you think fifth metacarpal, fight bite. You hear fall, you think scaphoid, distal radius. It's pattern recognition.
Moving to the physical exam. Inspection. What's the one thing to look for at rest that screams tendon injury?
It's the resting cascade. Just look at a normal, relaxed hand. The fingers curl in slightly, with the little finger bent more than the index. That's normal tendon tone.
So if one finger is lying dead straight.
That's a huge red flag. That break in the cascade suggests a cut flexor tendon and a total loss of that resting tension.
Okay, now the most valuable part. Isolating the tendons. Let's walk through the FDP test first.
To test the FDP, you have to knock out the FDS. The way you do that is by holding the PIP joint, the middle joint, in full extension. Pin it down.
So the FDS can't contribute.
Exactly. Then you ask the patient to bend the very tip of their finger. If they can, FDP is intact. If they can't, it's likely injured.
And for the FDS, the one that splits.
To test the FDS, you have to neutralize the FDP. The trick here is to hold all the other fingers in full extension.
Why does that work?
Because the FDP muscle belly controls all the fingers together. So when you hold 3 of them straight, the 4th one can't really fire on its own. It's neutralized. Then you ask the patient to bend just the isolated finger at the middle joint. If they can, the FDS is working.
And for the thumb extensor?
EPL is easy. Hand flat on the table. Ask them to lift their thumb straight up towards the ceiling. That's retropulsion. That's the EPL.
Let's talk neurovascular. For nerves, we need the gold standard. Why is two-point discrimination so much better than just asking, can you feel this?
Because of sensory overlap, you can have a completely cut digital nerve and still feel something because of input from adjacent nerves. It's totally unreliable.
But 2PD is objective.
It's objective. Normal is less than 6 millimeters. If you're getting, say, 10 millimeters or more, you have a confirmed functional nerve injury. That's solid documentation.
And a quick motor check.
Just remember the zones. Median nerve is the OK sign, with sensation at the index tip. Ulnar is finger spread, sensation at the little fingertip. And radial is thumbs up, sensation in that first dorsal web space.
Time for the special tests, the ones that really show you know your stuff. Let's start with Elson's test.
Right. Elson's test is for essential slip injury, which can lead to a boutonniere deformity.
How do you do it?
You have the patient bend their PIP joint 90 degrees over the edge of a table. Then you ask them to straighten that finger against your resistance. What you're looking for is the DIP joint, the tip.
What does it do?
If the central slip is torn, the DIP joint will feel floppy, or it might even hyperextend. That's a positive test. It means the lateral bands are taking over and the main extensor mechanism is broken.
And the test for a skier's or gamekeeper's thumb?
That's the UCL stress test. You're checking the ulnar collateral ligament of the thumb's MCP joint. You gently stress the joint sideways, both in slight flexion and in full extension.
And what's considered a positive test?
If you find laxity of more than 30 degrees compared to the other side, or, and this is key, if there's no firm endpoint, it just feels soft and keeps it going.
Why is that so critical to catch?
Because it puts them at high risk for a Steiner lesion. That's where the torn end of the ligament gets flicked out and trapped. If that happens, it can't heal on its own. It needs surgery. Moving on to imaging. A quick pearl on foreign bodies. Glass, if it's over 2 millimeters, is usually visible on X-ray.
But what about organic things like a wood splinter or a thorn?
They are radiolucent, they won't show up. If your history is screaming retained foreign body, but the X-ray is clear, you have to get an ultrasound. Otherwise, they'll be back with a chronic infection.
And let's revisit the scaphoid. The X-ray is negative, but you've got snuff box tenderness and pain on axial loading. What's the rule?
The clinical picture wins. Always. If the exam says fracture, you treat it as a fracture.
So you mobilize them in.
You put them in a thumb spica and you arrange for follow-up imaging, often an MRI or CT. You can't risk missing it and having that bone die from a vascular necrosis.
Let's shift to management. Wounds and blocks. For a digital block, we're using plain lidocaine or bupivacaine. There used to be this absolute rule against using adrenaline.
Right, the old dogma. Modern evidence shows it's probably safe in healthy digits, but there's a huge caveat.
Which is?
You must avoid it in anyone with peripheral vascular disease, Raynaud's, or any compromised circulation. In those patients, the risk of vasospasm and digital necrosis is still very real.
And antibiotics for bites. You mentioned coamoxiclav as first line because it covers Icanella. But what if your patient has a serious penicillin allergy?
Great question. You can't just skip it. You have to have a backup. Usually it's a combination, something like ciprofloxacin plus clindamycin. You need to cover those specific bugs. Always check your local guidelines, but make sure you cover them.
Okay, fracture principles. Let's talk about the common boxer's fracture. You said we can accept a lot of angulation.
We can. Up to 40 or even 50 degrees of volar angulation at the 5th MC neck.
50 degrees? That sounds like a crazy amount of deformity. How do you justify that?
It sounds awful, but it's because that 5th metacarpal is so mobile, it compensates. Functionally, it doesn't impact their grip strength as much as you'd think. You just strap it to its neighbor. But remember, rotational deformity is still unacceptable.
And the bright line for tendon injuries. ED versus specialist.
Simple. Flexor tendon injuries go to the surgeons, period. It's often called no man's land for a reason. Repair is complex, adhesions are a huge problem. Your job in the ED is to identify it, clean it, close the skin, and make an urgent referral. Don't touch the tendon.
But a closed mallet finger is different.
Totally different. That's an extensor injury, zone 1. That's managed conservatively. A stack splint, 247 for 6 to 8 weeks, and you have to be strict about it.
Okay, let's detail those Kanavel signs again. What are the 4, and why is one of them the most sensitive?
Okay, the 4 signs. 1, fusiform swelling. The whole digit just looks like a sausage.
Got it.
2, the finger is held in slight flexion. This minimizes tension and pain. 3, and this is the most sensitive, 1 pain on passive extension.
Why is that one the most sensitive?
Because you are physically stretching that infected, inflamed, pressurized tendon sheath. It causes excruciating pain. And number 4 is tenderness along the sheath. Management is 5E antibiotics, admission, and urgent surgical washout.
And we have to differentiate 2 infections that can look similar. A felon versus herpetic whitlow.
This is a classic pitfall. A felon is a bacterial abscess in the pulp of the fingertip. It's full of pus, and it needs incision and drainage. But herpetic whitlow is viral. It's HSV. It presents with little vesicles, clear fluid.
And what's the big mistake people make?
They cut it. Do not incise a herpetic whitlow. You risk bacterial superinfection, even viremia. The treatment is conservative with a cyclovir.
Finally, just to hammer it home one more time. High-pressure injection injury.
It looks like nothing, but it's a disaster inside. Paint, grease, whatever it is, has been shot along tissue planes, causing widespread chemical necrosis. It needs an immediate plastics referral for wide surgical debridement. The clock is ticking from the moment of injury.
Okay, let's talk about what comes next. Complications. What's the single most common problem after any significant hand injury?
Stiffness. Hands down, it's stiffness. And we prevent it with early mobilization for stable injuries. But if it's unstable, you have to splint it. And you have to splint it in the position of safety.
Explain that. What is the position of safety?
It's MCP joints flexed to 90 degrees, and the IP joints, the finger joints, at 0 degrees, so fully straight.
Why that specific position?
It's all about the ligaments. The collateral ligaments of the MCP joints are at their tightest, their maximal length, when the joint is flexed to 90. If you splint them straight, the ligaments shorten.
And then you can never get that movement back.
You get a prominent contracture. So MCP's at 90, IP's at 0. That position preserves ligament length and prevents stiffness. And another one to be aware of is CRPS, complex regional pain syndrome. There's actually a really interesting bit of prophylaxis for this.
Oh.
Vitamin C, 500 milligrams daily for 50 days after a distal radius fracture has been shown to reduce the risk. It's a small detail, but it can make a huge difference for that patient.
We should also flag the risk of delayed tendon rupture, shouldn't we?
Yes, specifically the extensor pollicis longus, or EPL, it can rupture weeks or even months after a distal radius fracture. The tendon basically rubs over a sharp edge of the healing bone until it frays and snaps. You have to warn patients about that possibility.
Okay, let's wrap up with the final checklist, documentation. What are the absolute must-have objective details for the EM clinician to record?
This is what protects you. You need a system. Start with the basics, hand dominance, MOI, tetanus status, but the real defense is in the objective findings. You must record the exact result of your 2-point discrimination test. Don't just write sensation intact, write 2PD 8mm on ulnar aspect of index finger. And you need explicit notes on your tendon exam, digit by digit, FDP intact, FDS intact to all digits. Then your summary, your MDM, has to tie it all together. State that X-rays were interpreted, that a wound exploration was performed under digital block, and that you confirmed tendon integrity either by seeing it or testing it. Those specifics are what prove you provided specialized care.
That was a phenomenal synthesis.
Yeah.
I think by moving from just looking at a hand to truly mastering these specific maneuvers, the FDP, FDS, isolation, the rigor of 2PD, you really do elevate your practice.
You do. And as a final thought to take away with you, think about the extensor side of the hand. We talked about the EPL rupture, but the whole extensor mechanism, the central slip, the lateral bands, it's actually far more delicate and complex than the flexors. So if you leave here curious, go and look up the extensor tendon zones. See how a tiny cut in zone 3 can lead to a delayed boutonniere deformity. It's that delayed functional collapse that often becomes the most challenging problem to fix.
A great point. Understanding that potential for delayed failure is so important for good follow-up. Thank you for joining us for this deep dive. Keep those hands safe, and we'll catch you on the next one.